Good day everyone, and welcome to the new video in our series of intestinal infections. In today's video we will be talking about the first clinical syndrome of our infectious series, which will be diarrhea with little or no fever. During this mini-series we will be discussing diarrheas from a different point of view. We will be no longer talking purely theoretical and etiological agents. We will be talking clinical, where we will see it from the point of view of patients. As we said before, we will be classifying our patients into diarrhea with little or no fever, diarrhea with fever or dysentery, and vomiting, pure vomiting, and food poisoning. So first chapter will be about diarrhea with little or no fever. We start by the overview. First of all, the diarrhea is usually caused by gastroenteritis, which will be a exchangeably used term for our whole video. Gastroenteritis is one of the most common infectious disease syndromes, where each one of us, doesn't matter which specialty we will choose, we will be meeting such patients and we will meet such disease in our practice. Why is it important to know about it? Because 2.4 billion episodes occur each year worldwide. Most of them are children under 5-year-old in resource-limited countries. We have 500,000 deaths each year due to gastroenteritis. And morbidities remain significant despite the decrease in global mortality rates, because the development we are having in our countries or in our developed countries is not well observed inside even our countries, in rural areas and in underdeveloped countries or in remote areas. That's why morbidity is still important. Another important aspect to talk about is the emergence of Clostridium difficile, which is associated with increased mortality even in resource abundant countries. And this is because we have emergence of resistance within these patients, and because the severity is becoming even more and more with increased use of antibiotics without specific clinical indications. What is important to know that most episodes are self-limited. Most of our patients were recovered by themselves. Our job is to decrease the mortality when needed and symptomatic relief of our patients. Most of the disease, they are clinically recognizable by gastroenteritis, but we cannot differentiate etiologically. Either with fever or without fever, it will be hard for us to know the exact etiological factor simply by clinic. Usually, it is suggestive of toxigenic, bacterial, or viral, or non-invasive. But there is two specific pathogens that are quite important. For example, perfuse purging in cholera, it's fatal manifestation, and we should be able to clinically distinguish it to start infusing the patient fast and decrease the morbidity. This is one of the only etiological agents that we can clinically determine. And diarrhea persisting for over 2 weeks can be due to parasitic causes. It is important to remember these two ones because it's the only one that we can classify accordingly. As we said, in afebrile patients, clinical symptoms rarely indicate any specific etiology. Any etiology that causes afebrile gastroenteritis can also cause febrile gastroenteritis. And the absence of fever or blood in the stool will diminish the likelihood of an invasive bacterial or amoebic process and the urgency to treat it. That's why if we have a patient with diarrhea with no fever, it is not urgent for us to treat this patient. So this patient will need symptomatic relief, but not urgent intervention, as long as the patient is not severely dehydrated. If we would like to narrow down our etiological factors, it is important to ask our patient multiple questions and have previous knowledge about the epidemiology of our area. For example, we should know about local and seasonal prevalences, where each area or country has specific surges and drops within each etiology. We can have seasonal surges of specific etiologies or local outbreaks. We can check for host factors. For example, aged people have different etiologies from young people, and immunocompromised people will have totally different etiological profile. We should check for antibiotic use, because if the patient has recent antibiotical use, it can refer us that the patient is having antibiotic associated diarrhea, which is Clostridioid difficile infection. Environmental factors varying across industrialized and non-industrialized countries and community and healthcare environments. These, all of them, we should know. We should ask our patients all of these questions to be able to narrow down our etiological factor list, to be able to better manage our patients, especially in areas where we have limited access to tests. And the appropriate treatment is fluid and electrolyte replacement therapy. And it's the mainstay of treatment. So, diarrhea with no fever can be further classified into community-acquired diarrhea and other types of diarrhea. And within community-acquired diarrhea, it will be further classified. The first classification that we will use is acute pediatric diarrhea, which is diarrhea for less than 2 weeks for children. The highest attack rate for diarrhea is during 6 to 24 months, during the weaning period, when the child is eating and drinking less of mother's milk and eating more of food that might be contaminated. As we know, mother's milk has high antibody count, which is protective for the child's GI tract, while other food may be contaminated really easily. The factors that contribute to increased susceptibility of the children are poor hygiene during food preparation and contamination of complementary foods. For example, children who are starting weaning and have complementary food, not as main food. Sometimes people might think that this is a small amount and it's easy for the kid to digest it. What the parents don't know that this small amount can contain infectious dose that is big enough for the child to get infected. A lot of the time, the children playing outside can ingest soil by playing in the sand and putting their hand in their mouth. This is one of the reasons why kids are highly susceptible to diarrhogenic bacteria that is found inside the soil. And one of the biggest contributors in underdeveloped countries is undernutrition. So, the manifestation of early childhood diarrhea is acute, watery, non-inflammatory diarrhea. And as we see with children, the acute watery phase is really fast and the child can get dehydrated really fast. which leads into the high mortality of such children in underdeveloped countries where infusion treatment or oral rehydration solutions are not always available. So the cases are sporadic with seasonal patterns, not epidemics. And often they peak in summer months in resource limited settings. These diarrheas are short lived and resolve within 2 to 3 days with adequate rehydration, and in well nourished infants. This malnourished children will get severe and prolonged course of disease. If we talk etiologically, the most common etiology is rotavirus. Rotavirus is the most common etiology of acute childhood diarrhea. And if we are talking non-viral, it will be ETEC, which is enterotoxigenic E. coli. The use of molecular diagnostics has refined our understanding of the pathogen attributable estimates, which means that whenever we have a child in developed countries coming into the emergency department with acute watery non-inflammatory diarrhea, PCR testing is made most of the time for rota, noro, adeno, and sometimes sapo and astroviruses, and sometimes other viruses which are also popular are not easy to detect. For example, Campylobacter and Cryptosporidium. They are significant contributors, but they are not regularly screened. And here the use of diagnostics is more inclined into epidemiological data gathering than for clinical reasons. So, rotavirus, it's the most common cause of severe diarrhea in infants and young children globally. It causes millions of cases and thousands of deaths annually. As we said, mostly in low income to middle income countries. The good thing about rotavirus and why we have big accent on it, because we have vaccination programs that significantly reduce the related illness and hospitalization. The diarrhea caused by rotavirus is caused by non-enveloped RNA viruses. The major effects on the host are disruption of epithelia and especially the cell brush border enzymes. This cytotoxicity and alteration of the enteric nervous system will lead to replacement of normal epithelium with irregular cells, and these irregular cells will not have the same impact on the water balance inside the intestine. That's why we will have sometimes mild to severe gastroenteritis, and in severe cases it will include vomiting, and we will have dehydration. The diagnosis is established through molecular assays or culture of stool samples, most commonly is by PCR. The treatment mainstay is oral or IV rehydration. There is no antiviral therapy established. Nitroxoxanide or nefuroxazide has shown some effectiveness in shortening the duration of the illness. But the opinion of the scientific societies has been divided, as some of them think that these agents suppress the microflora that might be pathogenically affecting the intestine when the virus is changing it. So we will have facultative pathogens that start acting up when the virus is in place, and these antibiotics will have an effect of diminishing their effect. That's why not all doctors like to prescribe it. The same goes for probiotics, where probiotics will inhibit the facultative pathogens and will reduce repeated diarrhea. The episodes will be less frequent and it will promote faster healing of intestinal function. As we said, we have vaccines of rotavirus. It is safe and effective, and it has been a priority. The development have been a priority. The previous vaccine of RotaShield was withdrawn because it had a really high rate of correlation with interception in children. And currently we have two licensed vaccines. We have Rotarix and Rotatec. The routine vaccination has significantly reduced rotavirus-related illnesses and the healthcare costs attributed to them. Vaccine efficiency varies geographically and is lower in resource-limited countries because of less herd immunity effect. We have parentally administered subunit vaccine that showed promise but is still not licensed for use. And one thing to remember is that the rotavirus is contraindicated for people who have egg allergy. The second syndrome that we will talk about after acute pediatric diarrhea is acute nausea and vomiting, which is sometimes called winter vomiting disease. The syndrome of acute nausea and vomiting might be alone by itself or might be accompanied by later appearance of diarrhea. It commonly occurs in winter months in temperate climate, and it overlaps with rotavirus associated gastroenteritis. Rotaviruses are a relatively uncommon cause of winter vomiting disease in older children and adults. If we take the Cleveland family studies, we will see that gastrointestinal illnesses are most common between 1 and 10 years of age. Approximately 2 illnesses per person per year. The illness peak from November through February with lowest frequency in June. And this is attributed to the fact that during these months, people tend to crowd inside small places for better heating and better isolation. Most of them last from 1 to 3 days, and 20% of them occur with respiratory symptoms, and 20% involve only diarrhea as an additional symptom. Etiology of winter vomiting disease are calciviruses, which are noro and sapoviruses. We have 4 genera, which are vesivirus, norovirus, sapovirus, and lagovirus. Norovirus and sapovirus are the most common causative agents, and that's why they are regularly screened for people coming with acute nausea and vomiting with no extra symptoms. If we talk about norovirus by itself, it accounts for more than 1/3 of the outbreaks of non-bacterial gastroenteritis in the US. Person-to-person spread is common. Outbreaks observed in various settings including hospital, extended care facilities, child care centers, cruise ships, and military combat areas. And as we said, this is all places where we have crowding of people. We have several genotypes known to infect humans, pathophysiologic features, parallel features of rotavirus. That's why we will not talk about the pathogenesis as it is almost the same. Sapovirus has greater burden of diarrhea that has been unmasked in low income to middle income countries. Second most common cause of etiology of diarrhea in community settings. We have cumulative incidence of 80% by 2 years of age, which means that 80% of the population by 2 years of age will have at least one episode of sapovirus. The symptoms overlap with norovirus and can cause outbreaks in long-term care facilities. So the other viral etiologies that can cause winter disease or winter vomiting disease are other types of calciviridae, astroviruses, adenoviruses, human enteric coronavirus, and other agents. These agents has been identified as endemic and epidemic gastroenteritis. Astro is among the most common causes of pediatric viral gastroenteritis. Adenovirus 40 and 41 are the most common viral etiology of moderate to severe acute diarrhea in children in low-income settings. And we should always remember that respiratory viruses can also cause vomiting and diarrhea through direct effect on the GI tract or through intoxication syndrome. Diagnosis of winter nausea sickness could be by nucleic acid based assays or PCR, reverse transcriptase ECR, because this is RNA virus of stool specimen, and this is the standard screening method for almost all patients who come with such symptoms. We have specific rota and neuro-specific PCR tests, but they are rarely performed in outpatient clinical settings. If we are talking about low to underdeveloped countries, or if we are talking about typical outpatient setting, but if the patient has to be admitted into the emergency department, most of the time these tests are taken. Then we go to diarrhea due to enteropathogenic bacteria. So we have talked about acute pediatric diarrhea, acute nausea, and now we will talk about diarrhea due to enteropathogenic bacteria. So we start by diarrhogenic E. coli pathotypes. E. coli has multiple types. We start first of all by enterotoxigenic E. coli, which is ETEC, enteroaggregative E. coli, enteropathogenic E. coli, enteroinvasive E. coli, and Shiga toxin producing E. coli. Not all of them can cause pure non-inflammatory can cause inflammatory diarrhea, but almost all of them can cause non-inflammatory diarrhea. So, other bacteria that can also cause non-inflammatory diarrhea are Shigella, Salmonella, Campylobacter, which can cause inflammatory diarrhea. And we have Vibrio cholera and non-cholera Vibrio species that can also cause non-inflammatory diarrhea. The most common worldwide are Shigella and ETEC. The risk factors are also between 12 and 24 months, which is the weaning and the start of eating multiple foods for children. And if we have antibody against the heat-liable enterotoxin of E. coli, it may reduce the burden in infancy. What is interesting to observe is that diarrhea caused by heat-liable toxin of E. coli has the same mechanism of the cholera toxin. Certain strains of Klebsiella, Citrobacter, Aeromonas produce a LT-like toxin and may cause diarrheal disease in children, but this is rare. But they all have the same structure of the toxin. If we talk about enteroaggregative E. coli, it is frequently subclinical, but it is commonly identified, since if we can culture the stool, we can find the EAEC. It is universal infection in children in resource-limited settings, and it is associated with growth impairment. It is usually a co-infection with other types of E. coli or Campylobacter. Why is it important to talk about growth impairment? Because cumulative and diverse pathogen exposure are associated with growth impairment in the first 2 years of life. Early life gastrointestinal infection in low research setting has substantial potential cost because these developmental growth impairment that happen in the first 2 years of life of the child can have long-term effect, and this has been proven to have a big burden on healthcare systems in low resource settings. So we start with diarrhea in adults, where viral causes are the most common. We will remember that norovirus is the most common, which is similar to in children. Rota and adenoviruses are also, but in adults we can add enteroviruses, which are the Coxsackie viruses. And bacterial causes play an important role in gastroenteritis in adults. And especially we talk about Clostridium difficile, which is now called Clostridioid difficile. It is associated with recent antibiotic use and potential for recurrence of the gastroenteritis. We'll have non-typhoidal salmonella, which are important cause of foodborne diarrhea outbreaks with fever, but sometimes they can cause without fever. It is also always important to remember that every single organism that can cause diarrhea with fever can cause diarrhea without fever, but the opposite is not correct. Clostridium perfringens, Bacillus cereus, Staphylococcus aureus, which are agents of food poisoning, can cause diarrheal symptoms. It is important to take a moment and talk about cholera. Vibrio cholera has historical impact and notoriety, and is important to know because outbreaks of cholera has high mortality and can be clinically diagnosed. We are currently in the 7th pandemic spread across South Asia, Africa, and parts of Europe. And now during 2023, we can see recurrence of cholera in Haiti after the tsunami. We can see it and the earthquake. We can see it in Turkey after the earthquake. And we can see it in war-ridden areas of the world. That's why, other than these areas where we will have small outbreaks, we can have rare isolated cases in the United States and Europe, and it is usually because of seafood ingestion. Epidemic cholera is caused by non-O1 V cholera, which is called O138 or Bengal. It has started in 1990s and is still continuing until today. We have large outbreaks linked to natural disasters and social conflict, as we said, as in Haiti and Yemen. The clinical features are severe watery diarrhea, potential for hypovolemic shock and death. Severe watery diarrhea will have the shape and the color of rice water, which is the water that we have after cleaning rice, and it will have a really pungent smell. The patient will be having profuse diarrhea and can be vomiting at the same time, and the dehydration will be so severe that his eyes will be rolling up. We have activation of intestinal adenylate cyclase by cholera enterotoxin. We have bacteriological diagnosis through stool culture, but usually the diagnosis is made clinically and then confirmed bacteriologically. And we should replace fluids with isotonic or oral glucose electrolyte solutions. And there is a special WHO approved solution called the Dhaka solution. Dhaka is the capital of Bangladesh, and that's how the name was brought up. And it's the WHO approved solution for severe cases of cholera. Sometimes the treatment uh, might be added of antibiotics like doxycycline for cholera. If we take cholera-like syndrome caused by certain strains of ETEC, they can cause it with fluid accumulation because the heat-labile toxin has the same effect as the cholera toxin inside our intestine. But it activates the adenylate cyclase, but the heat-stable toxin activates the guanylate cyclase and has a little bit of different characteristics. So ETEC producing only LT or ST only producing or producing both can cause diarrhea. People can have asymptomatic carriage in resource limited settings, especially when the patient didn't have the appropriate treatment. So ST producing strains are associated with diarrheal disease, which are more severe, and it is less common in the United States. After talking about adults, we should stop and talk about immunocompromised patients because they have their own etiological profiles. So patients with HIV infections have decreased, especially since the beginning of the HIV pandemic. The incidence of infectious diarrhea has decreased in this population from the 1990s, since the high intensity of antiretroviral therapy started. But it is still a lot higher than the non-HIV infected population. And among HIV infected patients meeting the AIDS criteria, 30% to 60% present with diarrhea, and in some regions it is 95%. And profuse chronic diarrhea is one of the hallmarks of AIDS. It can be prolonged, severe, and life-threatening. Interaction between HIV and intestinal immune components play a role in modulating the systemic HIV infection and play a role in preparing the ground for enteric pathogens. These pathogens are found in 55 to 85% of AIDS patients with diarrhea, and the leading agents include Cryptosporidium, cytomegalovirus, and Microsporidium. The others are less common, but still important to note: Entamoeba histolytica, Giardia lamblia, Salmonella, Campylobacter, Shigella, Vibrio parahemolyticus, Clostridium difficile, and Mycobacterium species. Cyclospora and Cystospora also cause persistent diarrhea in AIDS patients. Pneumocystis jirovai can involve the intestinal tract as additional symptoms. It is important to note that men with HIV who have sex with men are at increased risk of specific pathogens. Most patients respond to specific antimicrobial or antiparasitic therapy if added to ART. If the patient is susceptible or diagnosed with CMV, then Janciclovir is the effective treatment. Chronic diarrhea in HIV-infected patients poses a management challenge. Practical algorithmic approach can aid in diagnosis and management. Another important population to note is patients with solid organ transplantation or on immunosuppressants. The risk factors are chemotherapy, anti-rejection medication, and immunosuppression. Prolonged hospitalization and antimicrobial use contribute to the high rates of Clostridium difficile infection. Transplantation of any organ is associated with increased risk of CDI. Specific infections are norovirus with prolonged shedding and symptoms that are persistent for more than 2 weeks. CMV should be considered especially if we have donor-recipient mismatch. Diarrhea can be also by disseminated adenovirus. Cryptosporidis can mimic the graft versus host disease. And we should always remember that it can be medication side effect and chemotherapy. They might be the sole cause of our diarrhea. That's why these patients need specific multi-specialty diagnosis and observation before we start the management. One of the management that we can use is the reduction of immunosuppression. Ganciclovir is effective against CMV when diagnosed properly. And specific therapies and combinations of oral immunoglobulins, nitazoxamide, and decreasing immunosuppressive therapy may benefit some patients. And if the patient is having Clostridium difficile, then it should be treated with the specific protocols of CDI. Norovirus, CMV, and adenovirus are common pathogens. Another type of diarrhea that we should take some time to look into is traveler's diarrhea. Why it is important? Because it disrupts the traveler's daily activities. It is characterized by abdominal discomfort, urgent bowel movements, significant disruption of daily activities of the affected individual. It always is with sudden, uncontrolled urge to rush to the bathroom and can severely disrupt the sleep pattern and interfere with the normal routine. That's why the individual may find it challenging to engage in planned activities and attending important business meetings, and it has really big physical and emotional toll because, first of all, if we don't talk medically, these patients have invested money or traveled for specific reasons. Some of them has meetings, some of them has goals to finish within these small travel, because if you are sick in your own country, you can wait few days and then go and finish your goals. But when you are traveling, you are on a strict schedule. Or you can lose your only rest and holiday, spending it on the bathroom. So, traveler's diarrhea can lead to dehydration, which is a common complication of this condition. It manifests through dry mouth, excessive thirst, and lightheadedness. In severe cases, medical intervention through IV fluids may be necessary. The unpredictable nature of the symptoms, which come in waves, can cause emotional distress and heightened anxiety, especially that the patient which is traveling is already in a hyper-stressed situation. The travel experience will be diminished for these patients, and financial implications might be severe, especially that people traveling might not have accessible healthcare or free healthcare as they have in their own country. So, most of all, business travelers are particularly affected since it can lead to loss of productivity and loss of potential income. The epidemiology. We have variable attack rates. The attack rate of traveler diarrhea can range between 5% or 50% depending on the destination. Certain regions, such as Africa, Asia, Central and South America, exhibit higher rates. Attack rate variability may be influenced by factors such as local sanitation and hygiene practices prevalent in different regions. Traveler's diarrhea presents as an increased risk in specific geographical regions. Notable high-risk areas include Africa, Asia, Central and South America, where it is more prevalent. Within Asia, India stands out. Popular tourist destinations such as Mexico and Thailand also exhibit a really high prevalence of this condition. So the risk factors are consumption of contaminated food and water. That's why our food should come from reliable sources by reading reviews and doing proper research before traveling, and by drinking only bottled water. Poor hygiene practices, including inadequate hand washing or improper food handling, may contribute to the risk of contracting the condition. The duration of travel and specific risk factors are associated with different destinations, which further influences the susceptibility. Certain populations, such as young children and immunocompromised individuals, are particularly susceptible. And some scientific literature may indicate that the change in normal microflora and the change in the amount of oil, spices, and factors that influence our normal microflora might make us more susceptible, which is by some scientific opinions that argue more important than the pathogenic bacteria itself. We might have seasonal variations where we have higher incidence during the rainy month or the hot summer month, and areas with inadequate sanitation and infrastructure will have an increased risk of traveler's diarrhea during these seasons. How it is diagnosed? First of all, it can be diagnosed through clinical presentation. The patient will have malaise and anorexia, will have abdominal cramps. The water diarrhea will have sudden onset, and nausea and vomiting are up to 25% of the cases. Low-grade fever can be found in 1/3, or it can be subclinical. Duration is from 1 to 5 and can stay until up to 10 days. The most important etiological factor is, of course, ETEC or EPEC, but ETEC is still the main. Enteroinvasive can be, enteroaggregative can be, and sometimes it can be viral. Other bacterial pathogens are uncommon, but they still exist. Diagnostic consideration are stool examination for parasites, and we should look for pathogen-specific prevalence or the epidemiology of the destinations. The travel history and symptoms are important for diagnosis, and we should consider other potentially serious infections like malaria and typhoid fever. Clinical features we already talked about. We should add that it comes with dehydration, and symptomatic treatment is oral rehydration with glucose or sucrose. Bismuth subsalicylate or peptobismuth is for symptomatic therapy and prophylaxis. Antimotility agents are not recommended as they can prolong the disease. And of course, adequate hydration is the mainstay therapy. We can have empirical self-treatment where fluoroquinolones or azithromycin might be used. Sometimes levofloxacin is more preferred, and for children, TMP SMX is traditionally suggested, but we have seen a pattern of resistance. Rifaximin has been used, but in a lot of the newer protocols has been taken off, and combination therapy with loperamide might be indicated if the symptomatic relief is urgently needed. And the consideration of up-to-date reported susceptibility pattern should be according to destinations, since some of these destinations might have pathogens that are already resistant to such antibiotics. And in our new era, it is really easy to check the protocols of the country where our patient has just came from. Prevention of travel associated diarrhea is by avoiding high risk foods like salads and raw vegetables. Be cautious with bottled water and other beverages, and be careful when eating and drinking, especially in highly endemic areas. Prophylactic measures are taking prophylactic antimicrobial agents, but it should be used only selectively. It is considered for high risk individuals, especially those are with people with comorbidities or those who need to remain disease free. This is not for people who want to remain, or for those who need. We can have pre-traveling counseling where the patient is educated, provided information and epidemiological status of the destination, and taught about the safety precautions and the importance of hygiene. Post-travel evaluation is persistent or severe diarrhea that should be evaluated. We should be assessing for potential complications and stool testing. Key: diarrhea in institutions. We will talk about hospital and long-term care facility acquired diarrheas. The diagnosis is quite simple. Any patient in long-term care facility that starts having diarrhea, we should directly start immunoassays or PCRs, or we should test for Clostridium difficile toxins. Both of them should be promptly diagnosed because Clostridium difficile or antibiotic-associated diarrhea should be directly treated in those patients. The mortality is really high. So if we are talking about nosocomial diarrhea in newborn, they are particularly susceptible, especially because they have underdeveloped intestinal microbiota and limited immunity. Crowded conditions such as nurseries facilitate this transmission. Delayed recognition of an outbreak can occur as infants develop diarrhea after hospital discharge. Clinical presentation of neonates is by them being restless, poor feeding, watery stool, and signs of dehydration. The etiological agents are EPEC, EHEC, ETEC, and viral. The most common viral are rota and adenoviruses. If we see nosocomial diarrhea in hospitals, we can see that it's a common problem, especially in pediatric or ICUs. Clostridium difficile is the most common, frequent, and serious case of nosocomial diarrhea. Rates range from 2.3 to 4 cases per 100 admissions in pediatric wards and up to 41% of adults in ICUs. The etiological agents other than Clostridium difficile are Klebsiella oxytoca, enterotoxin producing methicillin resistant Staphylococcus aureus or MRSAs, Salmonella, Cryptosporidium. And the problem with these pathogens that they are becoming more frequently and excessively resistant to antibiotics. If you are talking about long-term care facilities, then it is a significant problem that can affect the elderly and the economical structure of these facilities. Clostridium difficile remained a common cause. It is prominent because a lot of these patients are on long-term treatments, and sudden outbreaks within the patients may hint us into more of a viral agent such as rotavirus, adenovirus, or norovirus. If we talk about diarrhea in daycare centers, then the outbreaks is usually caused by viruses or bacteria. Rotavirus is common in infants, while Giardia is more common in toddlers. Cryptosporidium should be always suspected, and inflammatory diarrhea should be suspected if we have the symptoms of inflammatory, and then we should directly start the investigation between non-feverish and feverish to differentiate our patients. The treatment of acute non-inflammatory diarrhea consists of the following. First and foremost, rehydration is the primary focus. Oral rehydration is with glucose or sucrose aid with electrolyte and is given for patients who are able to compensate their losses by oral route. Bismuth can be used to reduce the enterotoxin action, and some people prefer to add to the bismuth activated charcoal, which also has proven its efficacy, but during the early stages of the infection. Low doses of antimotility may provide relief if without fever or inflammation, but it should be given with caution because they can prolong the infection. The novel analogs of glutamine may help reduce the severity of infectious diarrhea. Probiotics efficacy in treating diarrhea requires further investigation, but it is effective in reducing the symptoms. Micronutrients, particularly zinc, supplementation has shown benefit in managing infectious, especially in children, but it still needs more investigation. Onto chronic inflammatory diarrhea. Chronic non-inflammatory diarrhea, is more clinically directing us and diagnostically into parasitic infections if we are talking about immunocompetent patients. For syndromes of chronic inflammatory diarrhea include giardiasis, tropical sprue-like syndromes, bacterial overgrowth, and cryptosporidium. They should all be considered. Giardiasis is easy to diagnose using molecular tests. Other parasites can be easily diagnosed by microscopy. And treatment of giardiasis is metronidazole, tinidazole, or nitroxoxanide. Bacterial overgrowth in the small bowel may cause malabsorption and chronic diarrhea, and identifying it and performing quantitative cultures of the upper small bowel content are important. In these patients, antibiotic therapy may be considered in asymptomatic bacterial overgrowth, while asymptomatic should not be treated. These treatments should target both aerobic and anaerobic organisms. That's why the antibodies should cover both. Brain diarrhea is a self-limited idiopathic diarrhea, which we will talk about in a specific video by itself. And non-infectious causes should be excluded. This include medication side effect, non-absorbable agents, heavy metal poisoning, endocrine disorder, or after having a severe diarrhea episode, sometimes our GI tract needs time to regenerate the epithelial brush-like cells. That's why we might have symptoms of diarrhea without the actual pathogenesis of diarrhea. That's why a comprehensive evaluation is needed to determine the specific causes and the appropriate treatment. Thank you for watching the whole video about diarrheal infections with no fever. Our next video will be about inflammatory diarrheas or dysentery syndrome, which is diarrheal disease with fever. and we will go more deep into these agents that can cause non-inflammatory but can cause inflammatory. Thank you again for watching. If you have any suggestions, please write them in the comments. And if you want to receive the PDF version of this map, feel free to download it on our Patreon page. Thank you again for watching, and hope that it was beneficial for you and for your study. These videos are made to be able to understand what is going on and treat our patients rather than pass exams, and wish you to have a good day.